talking about environmental exposure with our patients, unfortunately, we keep finding a lot of important findings, and it's not our role today to discuss causality of environmental exposure in chronic fatigue syndrome, but as a clinicians, we do need to, we observe, and we do correlation in our patient. Exposure to low dose and chronic exposure to low dose of toxicant have different symptomatology than acute high dose exposure to toxicity. And this patient, the most important effect of environmental exposure will be on immune system. It affects immune system. It has neurotoxic effect. It has a cardiotoxic effect. And by affecting immune system, it affects both sides, adaptive and innate immune system. T cells and B cells equally will be affected. Environmental toxins, and I will say heavy metals, residue of herbicides, pesticides, water damage building with mold and mycotoxin. The list is actually more than 200 toxicants which patients are exposed. In the household, it's a plasticizers, very frequent. So what happens, the toxicant can affect cell, cause oxidative stress, destroy cell, and cause creation of neoantigens, which driving autoimmunity and driving autoinflammation. We bring a couple cases, and this is feel-good cases because we all need feel-good cases. It's making us come to work back. This is a gentleman, our patient for many years with this history of myalgic encephalomyelitis. And at one visit, at one point, he present with severe cognitive decline. His neurologist put him on anti-Alzheimer medication. And we did some evaluation, and this gentleman practically retained everything what he possibly can retain. And arsenic is 1,000 times more than he should have. And he also has mercury, and he has water damage exposure, water damage building exposure with mold and mycotoxin. We got very excited with his treatment, and he responded to treatment very well. So when he came with cognitive decline in Florida, he's 66 years old, he was already taking his driver's license off. He practically was given homebound assessment. He could not live without his wife. And after treatment, he got his driver's license back, he started traveling, he has fully recovered his cognitive function. And it's affected his myalgic encephalomyelitis. He started traveling, he started being more active. And we have different options to measure environmental exposure. We measure in blood, in urine, in whole blood, in plasma, in serum. And there is some tests hair, testing in hair. We can even test, there is possibility in some laboratory, immune activation and antibody to particular toxins. The most important treatment, it's support for the body detoxification processes. Liver is our kind of the detoxification factory, but it's required a lot of nutritional support with amino acids, with lipids, with vitamins and minerals. And this is why we do assessment of nutritional function to support detox. Personalized medicine right now allowed us to use genomics. The patient would have genetic test, and then we look in single nucleotide polymorphism, which many of them don't play a big role in health, but some already enough evidence to know that some genes, in particular polymorphism in particular genes, is responsible for glutathione processing in the body, for detoxification processes in the body. This technology, the picture of this, it's actually not a test. This is the clinical decision support tool for provider, for clinician. And we can find out how the patient, if there is a risk for some diseases, or patient can develop how patient will respond to some medication, or how the status of detoxification. And this is intervention. We don't talk today too much about how we pay significant time and spend time with patient on improvement gastrointestinal function, and we're doing comprehensive stool tests. If patients have constipation, we cannot even start detoxification process. And this is what we're doing to improve detoxification and help to get rid of toxins. This is the most important part, comorbidities which we treat, and it looks like in our meeting in 2 days, we saw that it's on the top of approaches that we need to address. Autoimmunity is present. Unfortunately, our patients have all kinds of mismatch of antibodies, which rheumatology doesn't want to accept them. And we also know from the research evidence that almost 77% of our patients have fibromyalgia together with ME/CFS, and up to 40% gonna have POTS, and 20% have all kinds of thyroid antibody, and most of the patients, a lot of patients have family history of autoimmunity. So we have to address. This is another case. We're going to talk about POTS, and we're gonna start with this case. There's a really important how soon patient get to our practice. This is young patient post-COVID, and post-COVID we see a lot of POTS, postural orthostatic tachycardia syndrome, but it's autonomic dysfunction because it can be neurally mediated hypotension, it can be hyperadrenergic symptoms when blood pressure is actually opposite, go up and not down. And this patient, she has this Sjogren's antibody. Her mother has myalgic encephalomyelitis. She has a lot of predisposition post-COVID. She developed illness. Most of her symptoms is POTS, and she ended up in our clinic. She was very nice to understand that non-pharmacological methods as important as pharmacological. We start her on medication, we start her on beta blockers, but she also started using compression garments, electrolytes. She pays her activity. She's, as of right now, starting medical school. She's fully recovered, under control, on medication. She's managing her life, and she's starting medical school. So here's a dysautonomia, and our lifestyle modification are very, very important, and it's help patient. But as much, we have to really personalize treatment, because for some patients, volume expansion is really important, and the fludrocortisone can help. For another patient, it will be beta blockers. We found really helpful research what Dr. Systrom done, and pyridostigmine we use particularly for patients who already bed-bound, and we actually have cases when we recover a patient where we're bed-bound and now we volunteer. It's a really good feeling. Fibromyalgia is very, very common. And in a group of patients with fibromyalgia, up to 40% of the fibromyalgia patients can have small fiber neuropathy. We have ability to do skin biopsy for small fiber neuropathy in office, but most of the time we prefer communicate and ask neurologists to help them, just because it's helpful to approve patient for immunoglobulin, and we can probably have plasmapheresis. And here we go, mast cell activation. That mast cell is a cell living in a tissue. It's a big cell holding granules with histamine, tryptase, and heparin, but it also have another mediators, many different mediators. Mast cell can degranulate due to physical stress, emotional stress. It's degranulated from the IgE because of allergy, but the reason is important. The mast cell may not degranulate, but still continue producing a lot of pro-inflammatory, fibrotic, antigenic, all kinds of mediators. The mast cell activation, the patient can be present with variety of the symptoms, allergy symptoms, a lot of gastrointestinal symptoms, nausea, diarrhea, lightheadedness. We sometimes present with globus symptoms, a lot of red flushing. It's very, very common in our patients, surprisingly. The treatment, the assessment, there is a lot of tests we can order, but it's very technically difficult. Some laboratory cannot perform properly. Even histamine, it's actually very short life, and it must be drawn and collected and practically put in an ice and centrifuge on ice. Not everybody can do it. Sometimes we treat this patient empirically. Important for patient to understand, we start with histamine blockers, H1, H2 blockers, and we use mast cell stabilizer. We have to stabilize mast cell to prevent from their degranulation, but we also may stop effects of all the different another mediators. Mast cell stabilization, I want to mention, I don't want to forget, when we remove toxin from the patient, we help mast cell do not degranulate, because exposure to the toxin will make mast cell degranulate more often. And we don't have time to cover how important to address sleep. If patient doesn't sleep properly, the glymphatic system, what we talked before, and Dr. Klimas mentioned, glymphatic system will work if patients sleep at night and goes through deep sleep as appropriate. And also, if patient doesn't sleep well, and at 3 a.m. patient is not sleeping, the liver will not detox also. So, and the same, the chronic pain and GI symptoms, as I already said, it's almost standard process for us to order comprehensive stool test. And I have to shout. This is the last case I want to show. So it's maybe not as great case as before. With our patient in 2010, she was diagnosed with acute parvo, and she was treated. She has acute anemia. She was treated with immunoglobulin, probably not long enough. In 2011, she developed myalgic encephalomyelitis. She got diagnosis. In 2019, we diagnosed her with mast cell activation and POTS. And as of today, right now, this year, she got this test, genetic test, and we measure immunoglobulins, and she has common variable immune deficiency. I want to finish right there and just say that this disease, we cannot measure and apply treatments in lab test of 2010 today, because disease develop, the patient lives through the life. We like it to be hold patient together, and she actually manage her life. But we have to continue and reevaluate you. And we start with the patient that we trust patient, that patient is sick and not tired. And we do everything we have to personalized care to address many things which I do not have time to mention today. Thank you.
Thank you very much.